When you go to the assisted living facility, you will see these disease processes for sure. These are kind of the benchmark of aging. If you live long enough, you get to have some of these fun things. So we're talking about atherosclerotic disease, diabetes, venous stasis disease, thrombotic diseases, Bernard's syndrome or phenomenon or disease, depending on what you want to call it these days, cellulitis, and lymphangitis. Hopefully you won't be seeing any lymphangitis. We'll also recognize abnormalities of pulses. We'll be talking about edema in the lower extremities a little bit more today. Also talking about how to document normals versus abnormals, God bless you, and looking at how you would do a Hohmann sign, how you would assess for a Hohmann sign for a DVT, and how you would assess for an Allen test. Okay? So general considerations when we're talking about arteries, veins, and the lymphatic system, they all kind of run in tandem. We even have lymphatic drainage, obviously, from the abdominal cavity. Those we should not be able to palpate because they should be deep. They should essentially be in the retroperitoneal space and be running adjacent to the spine, essentially, the anterior aspect of vertebral bodies. But the two most important diseases that we talk about from an arterial standpoint on a microvascular level is going to be diabetes, and on a macrovascular level is going to be atherosclerotic disease. And I always love when patients say, I've got heart disease. And they're like, but I'm having a hard time walking. And they can't possibly think that the two are related. Always remember that when we talk either macrovascular from an atherosclerotic standpoint or microvascular from a diabetic standpoint, it is a non-discriminatory disease, meaning that it hits every inch of your body. Okay? When you have heart disease and it's vascular in origin, you have vascular disease everywhere else in your body. It doesn't have to be that bad, but it is everywhere. And also when you have diabetes, look at the 5-pound bag of Skittles in my office, it's like your vessels are always hyped up on sugar, you know? So when your vessels are always hyped up on sugar and always in an inflammatory state, those blood vessels that are the smallest are going to take the biggest hit. So when we talk about venous issues, we talk about venous stasis disease. This is a lovely picture of somebody with venous stasis disease. Now as you guys walk around Publix and Target, you're going to be looking at everybody's lower legs. And we talk about thromboembolic events. So truly when we talk about venous stasis disease, we're talking about typically more the distal, more superficial, I should say, venous system. Or when we talk about thromboembolic events, we're typically looking more about the deep venous system within the legs. So we always start with open-ended questions, right? We always want to know if they've had any changes to their arms or legs lately. Typically, we don't see a lot of vascular changes to the legs. We typically have better blood pressures up there. We typically have better circulation in the upper extremities. From a dependency standpoint, our legs are always the lowest point. So we tend to have more venous and arterial disease in the lower extremities than in the upper. Subclavian arteries, just in general, don't tend to take as much of a hit as the lower extremity vasculature. So we ask about pain with walking, any cramps, any varicosities, have they had a history of blood clots? If we know that they've had a history of blood clots and they're female, always nice to ask if they've had a history of miscarriages, right? Some women will not equate a blood dyscrasia or blood disorder with the fact that they've had 3 miscarriages in the past, okay, where in fact they probably infarcted to the fetus. So we always use character, location, onset, duration, intensity events, palliative and provocative. Mainly when we talk about pain, remember when we talked in the past about neurogenic claudication versus vascular claudication, the story that the patient will tell you will be very different. When you have vascular claudication, the patient will walk, and the distance they can walk over time does progressively get less and less, just like neurogenic claudication, but the difference is when they sit down. So in vascular claudication, they sit, and then the pain gets better. A couple minutes, okay? Neurogenic claudication, because it's a compression of the nerve as it exits through the foramen, the minute they sit and they lean forward, or classically they'll be the ones who go to Publix and get the shopping cart and do this, because they can walk further because the nerves aren't under compression. Those patients, their pain is almost instantaneously better. So the intensity of their pain may not be any different. The distance they can walk is probably the same. They tell you the same story in terms of pain, But when we have a vascular issue, it is a lack of oxygen because they aren't supplying the muscle with enough blood flow. When it is a nerve issue from the low back, they can't stimulate the muscle to contract. So two different reasons, and because of that, the timing of improvement of the symptoms when they sit is directly different. Associated symptoms, they could have numbness, paresthesias, or paralysis. Typically when we talk about paresthesias and numbness, we think more nerve, but you could also have the patient who's chronically diabetic, who's walking around with a hemoglobin A1C of 8 all the time, knowing that normal is anything less than 6.3. So, but typically when we talk paralysis, that should really eliminate any type of vascular concern in our head. Really, that should point us toward nerves in the low back. When we talk about vascular signs, so coolness, we typically worry about arterial flow. We're not getting enough blood flow to the structure. If we have warmth, we're typically more concerned about a venous stasis issue. So they're getting plenty of arterial flow in, they just don't have the adequate venous drainage out of the leg. So typically the leg will be a little bit warmer. Changes in color, so changes in color, we'll talk about Bernard's phenomenon. That can be a vasoconstriction of the arteries, but sometimes when we get that change in color, it can be venous stasis disease. So those patients will have a chronic pooling of old blood in the lower extremities, and literally from basically the calf line down, it looks like they're wearing tube socks. You know, where the tube sock line would be and down, their leg looks like a tree trunk. Okay, it's scaly, it's dry, it's hard. You look at the rest of the person, and the rest of the person looks like they're Swedish. You know, they're white as the day is long, and their legs look brown. And it's not because they just forgot to put sunscreen right down there. Okay, it's because they have venous stasis disease. They can have ulcerations, and you can have ulcerations both from a venous issue as well as an arterial issue. So if we get it from a venous issue, it's because we have so much old blood sitting in the leg that we don't have appropriate return. And basically we lose so much hydration to the tissue that it starts to break down. And they get so swollen that you can't ever effectively heal the ulceration. When we get it from an arterial standpoint, we truly don't have enough blood flow going down there. So you could give them Rocephin till it's going out of style. And it's not perfusing that tissue because they don't have the blood flow to get down there, okay? Risk factors, we always talk about smoking. Again, your 4-pack a day, 1 cigarette every 18 minutes, okay? But it can be somebody who's just been a prolonged smoker. Other medical issues in terms of coronary artery disease, you have to educate your patients because they truly don't appreciate that arterial disease that occurs in their heart, or I love this one, occurs in their carotid arteries, occurs everywhere. Okay, diabetes occurs everywhere. And family history. Those patients who have a very bad family history of peripheral vascular disease will develop this earlier in life than anybody else who's been having the same bad habits all of their life. So in general, we inspect, we look for symmetry, we look for any swelling, we look for any skin changes. We palpate for temperature and texture. We want to make sure that they actually don't have tenting, that they're well hydrated. That's always a good sign, especially in kids, that they're well hydrated, that their mucosa is clean, you know, nice and moist, that they're tearing, that they've got good, they're not tenting on their skin. We palpate for pulses, we palpate for lymph nodes, auscultate for bruits. Everybody know what a bruit sounds like? Kink a garden hose. That's your activity for this evening. Just kink a garden hose and listen to it. That's a carotid bruit, or that's a bruit anywhere in the body. Okay. Remember, a bruit only occurs when you have, or it should only occur. Ooh, we'll do a little quiz here. How many people think that a carotid, or that a bruit anywhere in the body is always significant? How about never significant? How about sometimes? Okay, sometimes, right? It's very volume dependent. And it's very blood pressure dependent. So you could have somebody with a blood pressure that's in the toilet, okay, 60/30. They could have mean carotid artery disease. You will not hear a carotid bruit on that patient. Conversely, you can have somebody who's walking around with a blood pressure of 200/110, and if you stick a stethoscope to their neck, yeah, you're probably going to hear a carotid bruit, and they may or may not have any stenosis there. Okay, so it's a good clinical finding. It's not necessarily directly indicative of, oh my God, rush into the OR. I once listened to a lady, she had bilateral carotid bruits that you could almost hear with the stethoscope off her neck. Her bilateral carotid stenosis was 30% on ultrasound. So don't get hoodwinked, that's all I'm saying. And we assess for jugular venous pressure. So when who needs who needs an exam? Ooh, I almost died too. If they have any pain in their lower extremities, believe it or not, you will get people that have ulcerations to their fingers, particularly if they're throwing emboli to their hands and they're having vascular occlusion of their hands because they're throwing small emboli like off the aortic arch. So instead of shooting them to the brain, they'll shoot them down to their hands and you'll start to develop ulcerations there. So any type of pain, which acute arterial occlusion of anything, is painful. Any changes in skin temperature or color, any edema, any ulcerations, if they've had a history of stroke, history of emboli going anywhere, okay, can be to the arms, can be to the legs. Remember, you can have tons of plaque along the aortic arch, and it might not choose to go to the brain, which would be a good thing, right? But it can travel all the way down to the legs and kind of get nestled in a small vessel. If they've had a history of dizziness, so dizziness is kind of like fatigue, right? It's all over the place. So it could be an inner ear issue. It could be labyrinthitis, like an inflammation of the inner ear, but it could be vascular in origin, particularly to the posterior cerebellar area. And if we have any patients who have a history of cardiac or diabetic disease. So when we look at inspection, we look for size, symmetry, and swelling. We're particularly looking for those patients who have a history of lymphedema or who are at risk of developing lymphedema. Remember, whenever we disturb the normal lymphatic chain, and typically we do that with surgery. Every once in a while you can get it with radiation, but typically we do it with surgical intervention. We can develop this horrible swelling on one upper extremity or one lower extremity in comparison to the other, okay? Knowing that from an education standpoint, when you have a patient who has lymphedema, they typically will wear a sleeve. I think we've all seen women walking around with breast cancer who have a sleeve on one arm. They can never have blood pressure readings. They should never have blood draws from that arm. No sticks, no IVs placed in that arm because of the risk of infection, right? Truly our lymphatic system is supposed to help us fight infection. If it has been disturbed, disrupted, hence we will not be able to fight appropriately, okay? But truly we do see it most commonly, I think, with breast cancer, and it's directly related to how often they have had the lymphatic chain disturbed. So whenever they do a lymph node dissection for breast cancer, they want to get to negative nodes. If they closed the patient up before they got to negative nodes and they went back into her, her risk of lymphedema just went up, okay? One little node, they always take lymph nodes with breast cancer, by the way, just so you know, right? So one little node, or even like 6 or 7, isn't going to put you at significant risk for lymphedema. I think the risk is actually like 2%. It's very low. Other skin changes, we talk about color. So when we talk about cellulitis, so this is essentially cellulitis, remember that it's always good to take the purple pen or whatever magic marker that you have when you're walking around on the floor and delineate out where someone has redness. So that way when you go back the next day or when someone else goes back, you can see if it's better or worse. Remember that cellulitis is basically that inflammation of the tissue. You may or may not have an underlying abscess in that area. But cellulitis is just generally the inflammatory response of the tissue, so you get that redness to the skin. When we talk about lymphangitis, so lymphangitis is the lovely red streak. If you ever see the lovely red streak, you should always look down south, okay? So if the red streak's in the arm, you should look to the hand. If it's in the leg, you should look toward the foot, because lymphangitis will always travel proximal. It'll always travel toward the center. And it is essentially that infection infiltrating that lymphatic chain. So you get that inflammatory response of the lymphatic chain, and you get this lovely redness. Usually it's never that bold. You know, usually it's a little bit more subtle, okay? When we talk about Raynaud's phenomenon or Raynaud's disease or syndrome, or everybody calls it something different. But basically that happens a little bit more so in women than in men. They probably want to tag it in the lovely autoimmune categories. Remember, the autoimmune categories love to run in 2s or 3s or 4s. And they get basically a vasoconstriction of small blood vessels. So typically whenever they're exposed to cold temperature, they will get vasoconstriction. It is self-limiting. All you got to do is warm up the extremity and the symptoms go away. So typically there's no long-term sequela of that condition or of that phenomenon, because all you got to do is, we see it a little bit more so in people who live up north, but you just tell them to wear a glove or wear hand warmers during the winter, and typically that syndrome will go away. But it can be quite painful, and then of course as the area is revascularized, as it's re-warmed up, it can give the numbness and the pain and the tingling as well. But you'll classically see that complete pale aspect of their hands. And typically you see it more so in the distal aspect, and at least in my practice, I've always seen it in the distal aspect of all 5 digits. I haven't seen it like just along the ulnar or just along the radial distribution. So when we look at the upper extremity, we look at the axillary artery with branching into the brachial artery, radial, and ulnar. And always we talk about the radial in terms of getting a pulse, but when we do the Allen test, we'll actually be assessing the ulnar pulse as well. So when we assess for capillary refill, +2 is normal. Anything more longer than that is considered delayed. So what are we worried about in terms of revascularization of the structure? And basically, when we look at pulse amplitude, in terms of assessing the pulse, we should have a normal pulse. It should be, +2. So your cap refill should be 1/1000, 2/1000. Your pulses should be about 2. Your reflexes should be 2. They kind of made everything easy, right? It's nice. If we have bounding pulses, we'll talk about bounding pulses. So when we have a normal pulse pressure, that difference that we have between systolic and diastolic should be about 30 to 40. If it's 45 or 50, I don't get too excited, but it should be about 30 to 40. If we have a very weak, or what we call, sometimes people will call a thready pulse, then we'll worry about aortic stenosis. They're simply not getting enough blood volume out of the heart. Or most commonly, you'll talk about hypovolemia. They just don't have enough gas in the tank. They don't have enough to circulate around, and therefore your overall pulse is thready. When we talk about a very bounding pulse, typically you'll talk about aortic regurgitation. You can even see that with hypervolemia. So I would get that a lot in my ICU patients, that we would tank up and all of a sudden we'd weigh them and they'd be 5 kilograms positive. Okay, essentially 10 pounds over what they came in with. And shockingly, their pulses were nice and bounding. Of course they are. They've got 5 liters of saline on board. Fever will do it. Any type of anemia will do it. Hyperthyroidism will do it. Remember, hyperthyroidism likes people to be bouncing off a wall. It will cause cardiovascular changes, God bless you, in terms of we can have abnormal murmurs, right? Let's wait for you guys to jump in there, right? Abnormal murmurs with hyperthyroidism. Happy Monday. But we can also get that bounding pulse secondary to it, okay? That's the person whose eyes are very proptotic. They're kind of jumping off the wall. You can't get them to sit down. You'd like to give them a Xanax. Probably what you should do is actually assess their thyroid. We talk about a double peak. So that can be aortic regurgitation or aortic stenosis. Hard to palpate. I would say, honestly, you would need to have, in order to get it biphasic, you would need to have a double peak as well as a very bounding pulse in order to be able to actually feel that on someone. So we talk about a beat-to-beat variation. We look at left heart failure. When we talk about a bigeminy pulse, so this is a normal beat followed by a premature contraction. Typically, you can feel that. You can't necessarily auscultate it as easily, but this should be somebody who is, if they're having a substantial number of these, is actually hooked up to telemetry. So you'll be able to see it on the cardiac monitor. A paradoxical pulse, so we'll have a greater than 10 millimeter decrease in the systolic pressure and the pulse waveform during inspiration. Remember, normal is less than 10, okay? So you'll get that with pericardial tamponade. You can actually get it with constrictive pericarditis as well, so any type of inflammatory process around the heart. When we talk about an Allen test, we'll take a break at about 9:10, okay? We talk about the Allen test, so we're assessing for patency of both the radial and ulnar artery, and we want to do this especially if we're going to stick a line for example, in the radial artery, because the last thing you would want to do is destroy the radial artery by sticking a needle in it, for say an arterial line or an arterial blood gas, and not have appropriate ulnar innervation. That would be bad day. That would be a stat call to a hand surgeon, okay? So we're going to compress both the radial as well as the ulnar artery at the same time. Basically, we ask the patient to clench their fist for 30 seconds. Then we ask them to open their fist up. We should release the ulnar artery. We should see revascularization to the ulnar distribution of the hand. And then we should see appropriate filling. And then we're going to actually open the radial artery, and we should see essentially that pink, nice return of blood flow. And you can do it contralaterally, or not contralaterally, but you could start and open the radial pulse first, and then the ulnar, basically to assess that we have good collateral blood flow. You want to ensure that if you did something, because typically when we are doing anything, we're actually doing it to the radial artery. So we want to make sure that if we're going to do something to that vessel and we're going to injure it, which can happen, or we're going to thrombose it, that we want to make sure we have appropriate collateral blood flow. So we're palpating for lymph nodes. When we talk about the upper extremity, we look at the epitrochlear nodes, so those are around the elbow. You might get those if somebody has truly that lymphangitis in the lower extremity. Anybody know what the worst bite is? Like if you got bit by something, what is the dirtiest? Human, right? Okay, so human are the worst. So I love it when patients come in and they say they've got a fracture, of course, fracture of their hand, and there's this open, jagged wound, and you're like, did somebody bite you? No. We're gonna fight? No, I punched a wall. Okay, because if you were in a fight and you got bit, I was gonna give you a whole different kind of antibiotic, but since you just punched a wall, I'm just gonna give you some Caplex. Well, maybe there was another person there. Maybe. Because it definitely changes your treatment, right? When we talk about human bites, they are worse than dog bites, they're worse than snake bites, they're worse than brown recluse and black widow and all that nastiness that's out there. When we bite each other, which I don't recommend, and we will not be doing in lab, those are the worst. So we want to assess the epitrochlear nodes, because typically when we talk about bites that occur, they're usually not happening on the shoulder, unless you're trying to take a chunk out of somebody. But you also want to make sure that you're assessing the axillary lymph nodes. Okay, so we always think about lymph nodes. Remember, they should be about the size of a lima bean. You really shouldn't be able to palpate lymph nodes, quite honestly. Okay, they should be tiny. So if you're feeling them anywhere, that's kind of not a good sign. Okay, when we talk about axillary lymph nodes, we always almost exclusively talk about breast cancer. And when we talk about breast cancer, you've got to remember that within the chest wall, there are lymph nodes that actually go contralateral. So there are lymph nodes that actually cross the sternum and will actually drain to the contralateral axilla. I know, it's craziness, right? So from the medial breast on, say, the left side, sometimes they will actually drain to the right axillary area. So you got to make sure that you assess everybody for their axillary lymph nodes. If you're going to assess for epitrochlear lymph nodes, you want to make sure that none of those are enlarged. Remembering that 1% of all breast cancers actually occur in you dudes, right? And that you dudes have a higher chance of dying. No offense. Because typically when you're diagnosed, it's later in the stage of your cancer. So you got to make sure that when you're palpating the chest wall for any tenderness on a guy, you're actually making sure they don't have any unusual masses that would be there as well. So you want to look for size, mobility, and tenderness. Truly, they should be mobile. They should be small. They should be less than about a centimeter in size. Remember, a centimeter in size is about the size of a pea. So on most people, you're really not able to feel lymph nodes too much. And they shouldn't be tender on people. Okay, yeah, if you push hard enough on anybody, it's going to hurt. But they shouldn't be, that one area shouldn't be any more tender than any other area. When we talk about edema, and we look at the lower extremities particularly, because very rarely in the upper extremities do we get true edema. Typically they get lymphedema. They don't get a dependent edema. So we look for size, symmetry, swelling. We look for pitting or non-pitting edema. If we're unsure, then you look kind of at the forefoot, the ankle. So some people, I'm getting really old, you know, like some people, everybody remember cankles, you know, like your calf is the same size as your ankle. That should not be the case, okay, right? There should be a clear delineation between the calf muscle and the ankle itself. That goes back to Friends, right? I'm dating myself. Anyways, and we want to look at the hair growth pattern. So what's the first thing to leave the tree in the fall? The leaves, right? So when we have, what were some answers back there?
Who's a squirrel?
Squirrels. Following the squirrels. Well, we're gonna go with the leaves. So the leaves are the first thing to fall off the trees. Okay, so the hair is the first thing that you'll lose on your legs, and it's hard to assess on women because most women shave their legs, hopefully not most guys, but it's a whole other story. So, but the hair is the first thing that we lose in the lower extremities, right? And we lose that as a result of peripheral vascular disease. We don't have enough arterial blood flow truly getting to the skin to penetrate the dermis and all the lovely layers that allow our hair to actually grow. This is different than the head, right? So on the head, we can get male pattern baldness, we can get alopecia. Some people will lovingly try to pull their hair out because they've got psychological issues. On the lower extremities, though, it's truly a vascular issue. You'll get it a little bit with venous stasis disease, but truly you'll get it more so with arterial disease. So you can look at the legs and really about the calf line again, they will have lost hair growth. And you can look at, I love looking at guys, and they'll have hair kind of on the medial aspect, but not on the lateral. And kind of on this side of the leg, on the left side, but not on this side of the leg, on the right side. And truly you could trace with a marker where they are missing appropriate arterial blood flow. Just simply looking at where their hair pattern is gone on their lower extremities. Always look at the toes too, because they'll have lost all their hair on their toes, and then they'll march it up on their calves, okay? So we talk about pitting edema of the lower extremities. Think about, going back to CSI, do you really want to leave your fingerprint on that patient? So we look at the dorsum of the foot, we look at behind the medial malleolus and over the shins. So if we can push our finger in and it stays, then that's truly pitting edema, okay? So a little teeny divot is going to be slight, and this is very subjective, okay? Somebody's going to say, well, I thought it was +2. Well, I thought it was +3. Don't have an argument over it, okay? +2, +3, who cares? They got pitting edema, okay? You're documenting that it's there, but you're not going to sit there and it takes a while to resolve. Nobody's going to sit there and just watch the leg. Seriously, who's got time for that? Okay? So you're looking at, is it resolving as you're continuing to talk to the patient? Because that's one of the things you can do. You can go into the end of somebody's hospital bed, sitting there talking to them, you pull up the sheets, you're looking at their feet, push your finger. If they know that they have pitting edema, if their legs look gigantic in comparison to the rest of the body, push your finger in and keep talking to them. And if you look back down and your fingerprint's still there, it's probably at least +3, okay? So +3 is more severe, takes a while to resolve, takes a very long time to resolve as +4. Okay, there is actually a calculation that you can count over minutes of how long, whether it's +2 or +3, but truly the majority of people ballpark this. It's about a +2, it's about a +3, yes?
Is there any gauge if they have weeping out of like they have such edema that it weeps out of their skin?
By then I would just go to +4.
Okay.
Okay? If they're so edematous that the fluid is looking for an out route, aside from their venous drainage, they're going to be +4. And the way you would document that is you would say +4 pitting edema with weeping, noted. Because then it just kind of goes to how volume overloaded that patient truly is. And really when we're talking about that type of edema, we're looking at really bad congestive heart failure for the most part. Okay, for whatever reason, despite how much Lasix we're giving that patient to get volume off of them, it's not working. So that patient typically will have very bad congestive heart failure, and to boot will have very bad renal insufficiency as well. Okay. So we look at the lower extremities and we look at skin changes. We look for color, ulceration. We look for any type of thickness and any type of varicosities. Now these are not your little teeny spider veins. Okay, these are the patients who have horrible varicosities that are bulging, unfortunately for those patients, their venous system, their valvular system has become dilated. And typically, again, this is more your peripheral venous system within your lower extremities. This is not your not your peripheral, your superficial versus your deep, okay? Your deep system stays for the most part intact because it's within the musculature. So it has the added circumferential compression of your muscles to get blood flow back to your heart. Whereas when we talk about our superficial venous system, it's like in our skin. You know, it's like in the epidermis. It's in the dermal layers. It's got nothing. It's got no muscle around it to kind of give it the extra oomph and push it back to the heart. So those will tend to get dilated over time. We do see this a little bit more so in women, especially with women who have had multiple pregnancies and who have gained upwards of 50, 60, 70 pounds with their pregnancy, okay, each time. As my mother would say, you're not having a 40-pound baby, okay? Or we'll see it with morbid obesity, even somebody who's been chronically obese over time. So we're probably actually going to see more of this, unfortunately, just because I think, a quarter of the population, a quarter of the kids are now obese, right? Isn't that the latest statistic? Which is crazy. But we're going to see more of this over time. And this, for those patients who are chronically obese, it is not simply their superficial system, but it's their superficial and deep system. So they're always going to be harboring too much of that venous blood in their lower extremities. But again, the thickness typically goes to venous stasis disease. So again, that's more of your superficial venous system. You can get ulcerations both with your venous system if we're not returning enough blood flow, and we kind of have that dry, woody type appearance to the skin, or if we have it from an arterial blood flow issue because we're not getting enough blood flow to a wound to actually heal it. Think of a lot of our patients, especially as we go to the ALF, who are wheelchair dependent, bed dependent, and essentially because of that their legs are always down, okay, or their heels are always resting on something. And the color of the legs, again, getting that back to that woody appearance. Sometimes even with arterial disease, you'll get more of a rhubarb, they call it, appearance, which is that red appearance to the legs. That the tiny, tiny vessels are trying to compensate for larger arterial disease. And so they're trying, it's like the patient that you see, you know how, you know how when everybody drinks a couple beers, typically their cheeks get a little rosy? Okay, imagine that happening to somebody's foot all the time. And they get that because they have a little bit of a venous dilation or vasodilation of the very, very tiny, tiny blood vessels to try to afford for a collateral circulation to the foot. The minute you elevate their foot, if they're sitting, their foot will become pale because you're draining all of that microvascularization out of their foot. All right, let's take a little break on this slide. Go get some breakfast. We'll start back at 9:15.